Welcome back, everyone. Good morning, Amina. Good morning, Bob. Welcome back to Climb. It's great to have you back.
Good morning.
Thank you.
Thank you. Thank you.
So as I was getting prepared to talk about remote patient monitoring today, I asked a few of our customers about it, and I found that a lot of them don't know what it is. So let's just start there. Tell us, what is remote patient monitoring? What's it all about? Why don't we start? Amina, go ahead and start.
Sure. So remote patient monitoring is also known as remote physiological monitoring. And this is when, at least in the Medicare population right now, it's where you can give a patient a device and you're able to get real-time data into the provider. So this is not where you can upload your results later. This is real-time feedback. And so identifying patients that would be a great candidate for monitoring in between visits. And the goal is that if we catch things early, we would prevent unnecessary hospitalization, unnecessary costs incurred into care. So that's in a nutshell.
Yeah, and just
Okay.
to follow up, most patients, to just carry it a little step further, what Amina said, most patients, they go to their primary care physician every 6 months, roughly twice a year. Well, if you got a patient that's diabetic or hypertensive patient, a lot can happen in 6 months if not followed closely. And we can pick up trends by giving them these devices. And to elaborate a little bit more, for example, if a patient's at home and they check their blood pressure, it sends us that reading in real time, as Amina said, and we see it on a daily basis and we can monitor it. So if we see a trend where the patient's going in the wrong direction, we can intervene. And with these relationships we actually have access to the patient's electronic health record, so we can communicate back to the prescriber pretty rapidly.
Okay, so with that said, can pharmacists just do this on their own? Can a pharmacy just decide we want to do this and set it up, or do you need to be involved with a doctor or a provider?
So there are two ways to think about this. These
Okay.
are devices that are available, right? They could be patients that could benefit that are not Medicare. And this does not stop a pharmacy for offering blood pressure monitoring or weight management and support patients in a cash model, because we're entering the world of digital health, digital therapeutics. And I think pharmacies can set themselves up. Historically, pharmacists have always had patients come to the pharmacy to get blood pressure reading, right? And we give them a logbook. Now that we are able to do things digitally, I could see a pharmacy being able to use these same devices and come up with a cash price. So that's where I'm seeing that it's possible, because, for example, we have one of our pharmacists that manages lifestyle and weight loss. And so those patients a lot of times either have high blood pressure or have diabetes or are trying to lose weight. So giving them the scales and devices that communicate with her has been put in part of the program into weight loss. So that's kind of a cash is king model. But then I'll let Bob answer on the other side, so we both get to talk together.
Yeah, certainly. And that is a great model, Amina. And just to feed on that a little bit, we I don't know, a couple of years ago, our leadership team was meeting, and it just hit me one day that and I forgot what the topic was, but it dawned on me that we've got hundreds of patients coming in every day and getting blood pressure medications. But do we really know what's happening with their blood pressure? And it was embarrassing. I've got patients, and quite a bit older than Amina, that have been getting blood pressure medicine for me for 20 years, but we've never followed their blood pressure. That's one example, and we can do that with diabetes and so many other things. And like Amina said, even on a cash basis. But I think the original model was, if you can get in a relationship with a clinic, a lot of these services are billable through the clinic. And correct me if I'm wrong, Amina, you're the expert. So the pharmacies, and most of us, especially in the rural areas like we have good relationship with these providers. And the model, you have to present your model to where, Guy, and we could get into more than just remote patient monitoring there, but we'll stick to that, to where the physician's office can actually bill for this service. And then you create a contract, a split of revenue. We cannot bill Medicare for that, but the clinic can bill. So we use that relationship to help that patient take care of those patients remotely, and they can certainly bill for that service, and then we split some revenue.
Yes, and to add to what Bob is saying is that Medicare is looking at total spend, right? And imagine as a pharmacist, how many times a patient has left their doctor's office with a new prescription or increased dose of a blood pressure, and we fill it. And who knows what happens after that? So we might wait 3 or 6 months for a patient to go back. What if all those months the blood pressure was not under control? And also, Medicare has never paid for those devices. So most of our Medicare patients have never had a blood pressure monitor at home.
Mm-hmm.
So
Sure.
when Medicare opened this up and they called it the remote physiological monitoring, it was to increase access and to increase access in between visit. So Medicare has a model where it pays what we call the QHP, a qualified health professional, the doctor, the NP, the PA, who is the primary provider for this patient. But we know they are so busy, right, Bob? They barely have time to return your prior auths. They barely have time to see the patients that are waiting for them. And post-COVID, these gaps have even increased further.
Right.
So
Sure.
we see this as an ideal partnership where a pharmacy can go right to these providers and say, I want to be part of your clinical team, and I can handle the logistics of getting these devices to the patients. I can monitor and only triage to you what, warrants the provider to pay attention to. And so our team can be that clinical. And guess what? We can troubleshoot. We're the ones who can send extra batteries to the patient's home because they are not monitoring anymore. So if you look at it in terms of Medicare, this is where the collaboration matters. And I feel like pharmacists provide more value than just the data of blood pressure is up, blood pressure is down, but key points to educating these patients and getting them to the desired outcomes.
We've argued for years that we see the patient a lot more than the prescriber, and so this gives us a seat at the table, and we can help monitor that patient in between those 6-month visits. Like I said earlier, is we see them every month, and we have more communication with them than the prescriber. So we're in a better position to monitor this.
Sure. Well, and when you think about something like blood pressure, I mean, that can vary dramatically in any given day, right? I mean, you could get your blood pressure under control, but you go into the doctor and you're just nervous and your blood pressure's higher, even though it's been great the entire time, or vice versa. I mean, so blood pressure in particular is something, if it's being monitored every day, that gives you a much better picture than you just walked into the doctor's office and he's going to spend 15 minutes with you if you're lucky, and they look at just the blood pressure at that point in time. So that makes a lot of sense to me. Diabetics, I mean, the A1C you can monitor, and that's 30 days, something like that. It gives a feel of how things have been over the last 30 days. But even that, like you mentioned, if they're only going in once or twice a year, that just makes all the sense in the world. So let me ask this. So in either model, is there revenue do you sell these devices, or are you giving the device to the patient? Or I guess it's really up to you, but what would be the typical situation?
So if you're dealing with Medicare has specific guidance in that they have 4 codes that are available in the medical billing world. And the first code is what we call the 99453, where you're paid about $19 to $21 to just set up the device and connect it to a platform that can bring this data in. So this is whether you have a scale, a blood pressure. You could have 3 devices, but it's one fee to connect that patient to this cloud, right? And then after that, you can go ahead, and Medicare allows per month about $50 to $60 to either afford this device, afford internet for the patient. So a lot of times these devices, and the cost is not passed on to the patient. So Medicare has what we call the transmission code. And because some patients, we've had to pay cellular for some patients because they don't have Wi-Fi, right? So the provider has been given a budget, $56 to $61 every single month, to do whatever it takes to get these devices to the patient. So in our model and in the Medicare, the guidance that I've seen, no one is selling these products to the patients. And then lastly, you have the monitoring one. It's like every 20 minutes of interacting with the patient allows you to document your time. And 20 minutes is about $50, $55. And every additional 20 minutes is about $40. So there's a setup that if Bob was looking at a patient's blood pressure and it's all whack, before he calls the doctor, Bob is going to research. Did you take the pills? You know, what else is happening? Well, you at a Super Bowl party and you drank a lot. You had a lot of Doritos. Like, what is going on? And that time, a lot of times pharmacists would do that normally and not get paid. So having a monitoring ability to get paid has been a game changer to help the population.
Sure. So let me ask two questions from that. First, about the device. Will the device come from the doctor, or will the device come from the pharmacy? And then if the device comes from the pharmacy and you're getting reimbursed through the doctor, is that how that's happening, or?
Yeah, so I don't know what Amina does, but we actually set the patient up in the pharmacy. We want to make certain they're using the device properly, because as Amina said, some of them have never used one at home. And she mentioned cellular service. Certainly I'm in rural Mississippi. Majority of our patients it is a cellular service. So we have to get all that set up, and we do that in the pharmacy and make certain the patient is actually capable and using the device properly. So, and it is billed obviously again through the medical clinic that we have a relationship with.
Okay.
Yep. So we do very similar to Bob, where we get the devices and we become the navigators, right?
Right.
Just because pharmacy is already trained, very similar to DME, right? So you get the devices for the patient, you set it up. Now, in order to bill for that device code, so we can make sure the provider can pay us, the patient has to test or use the device 16 days in a month, right? So you have to motivate the patient to give you 16 readings. Then you're able to bill the 99454. And when you get that money, it allows you to afford to keep these devices.
Right. Brad, quick example of how this happened. I just thought of this. Today is Tuesday. Yesterday morning, when I came into the office, I heard my team calling one of our patients and pointing out that we got some low blood pressure readings over the weekend. And he questioned that patient on what was going on. As Amina said, it was anything particular that was going on, because this particular patient, her blood pressures were extremely low. So he was able to pick that up over the last several days. And I'm not sure what action he took and what the result was, but I just overheard that conversation yesterday morning.
Okay. So that's a great example of where this thing works. As I'm listening to both of you, and I'm assuming that these people that are listening today that have never heard of remote patient monitoring or don't know much about it, this sounds hard. So tell me, what is there? There must be some technology that helps you through this, or is it difficult?
I think the hardest part for pharmacists is to get their collaborating provider, you know?
Okay.
But technology is a dime a dozen. These things are available everywhere. That's the easy part.
Right.
You can get a platform, you can get devices, unlocking your partner, unlocking that potential biller as a provider who wants to work with you, I think is where most of the pharmacists have struggled.
Well, and Amina was certainly the pioneer in this, and I can remember on the beginning talking to her, she said that's going to be your biggest hurdle is getting in that first clinic. And looking back on my experience, that was exactly correct. It took us 6 months, but once we got in that clinic and proved our value and showed the prescribers and the medical clinic how we could work together, then the next few clinics were a lot easier.
So there's multiple software platforms. It sounds like multiple platforms. So when you get your provider signed up, then and you do your first patient, and you get them, you're on Medicare, and you get them the devices, and you get them you get them 16 days or all those things that you have to do. Is that software communicating with the provider, and the provider then has to do something, or is it the billing just happen in the background?
Provider. So you become the provider. So also what I tell folks is before you go and sign up for a platform, maybe that provider you're working with already has a built-in remote monitoring in their electronic medical records. That's why I say leave technology last, right?
Okay.
It's very similar when pharmacy was evolving into patient care management. Not all of our dispensing systems had e-care plans, right? So we had to go outside and get technology that had it. And now many pharmacy management system have it. So I'm seeing trends where 2-3 years ago, remote monitoring modules were not in the medical record, EHRs, the electronic health records, but now we see there's a marketplace within and they can turn on that module, right? But the idea is that whether you turn that module into the physician's electronic medical record or you have a standalone, your pharmacy team is the one that gets those alerts. That is the benefit of your partnership. Provider is already overwhelmed. They don't need 500 alerts every hour.
Sure. Well, and that, I think that was kind of where I was going, because, you know, I'm like, is this a tough sell to the provider, because now the provider has extra work to do, but it doesn't sound like the provider, once you've signed them up, if I'm understanding this correctly, once you've convinced them to do this and you sign them up, then they don't have to deal with the billing. You're taking care of that under their umbrella.
No, not the billing. So you're taking care of the service. Okay. You're taking care of the service. They have to bill it, whether they teach you and allow you to go and adjudicate those claims within the system, because the money is going to go back to their account and you're going to have to reconcile with them to pay you for the patients that you've monitored or you've serviced. So a lot of times pharmacies use that the billing, and billing is used loosely. Well, this patient does not belong to us. We're the clinical extenders for the providers. So we are contractually doing the service. They have to bill for the service, but we can make it easier and easier every day.
Now, I know we Brad, answered, to maybe help with that. We certainly work with the biller to make certain they're billing what we're doing correctly. And once we, I guess, and I don't know whether Amina does that, but we certainly monitor them for a while to make certain that our services are getting billed. And again, we have access to their records. So we'll see when that payment comes in, and we'll see, we track obviously how much that provider owes us, if that makes sense.
Sure. Okay. So it actually doesn't sound too difficult. I mean, I think that was, when I was listening to the discussion initially, it was like, wow, this sounds hard.
It's like anything else, it's a little work on the front end. It's not complicated, but once everybody understands and gets on the same page, then it flows. You think about it, the patients that we're working with, they unless there's an issue, everything's going well, but we are monitoring it. So there's very, most states have collaborative practice agreements. So we could actually make the changes ourselves and never have to bother the prescriber.
Yep. This is a good, I feel like a good step towards pharmacy and providers coming close together and getting more delegation in helping them manage these complex patients.
Sure. So and I imagine this has to be different, because if there's multiple software platforms, everyone is going to do things a little bit differently. But generally, I would think, or tell me about how you're monitoring. Let's say you've signed up 500 patients. I don't know if that's realistic or not, but let's say you've signed up 500 patients. You obviously don't have time to look at 500 patients' records every single day. I wouldn't think, unless you have a staff member that does that full time. So how do you monitor?
Our technicians get up in the morning, they get into the dashboard and it's color coordinated. So
Yes.
it sorts with the red, yellow, green. So they won't prioritize the patients that are within the normal range. They'll definitely go through the red and they'll either call the patient to figure out the first things is like, did you take your medication before we got these numbers? If the patient says yes, then they'll retest it again, then they'll escalate it to the pharmacist. So because this is not meant like emergency, so if we didn't see it right off the bat, we're not in trouble, right? It's meant for chronically monitoring the patient. But most of all these systems have a system where you can just identify those that you should worry about right away.
Yeah, the platform makes it easier. As she said, they color code, obviously the red patients. We want to act on those, first. So sure. The platform makes it easier, I guess, is the simplest way.
Yep.
So in your cases, what's been the overall impact of implementing RPM?
Well, from the clinical side, again, we're creating that relationship, and this turns into other relationships as well. You're creating a bond there with those prescribers that you've had, but now it's making that bond even stronger, and they start relying on you for other information. It leads to other things, which leads to more revenue that's not subject to DIR fees and clawbacks, and there's no product involved other than the device itself once it's paid for. So it's a service. We're finally getting paid for clinical services.
Yep. And also what we noticed is patients who are being monitored do better. Mm-hmm. For whatever reason, if that number is facing them, they are improving. Because once we get patients on these devices, it takes 1 or 2 months and it's corrected. So I think that has been a huge benefit for the practices.
One of my favorite sayings is anything measured improves, and anything measured and reported on improves exponentially. So that backs up what Amina says. It's amazing when you start monitoring how much better they do.
Sure. And I think that makes sense psychologically for people. They know that it makes total sense. So, and I guess that creates some loyalty, I get as well, with the patient who now feels better, and also with your provider. So I can see those as...
Especially when you have, I know we talked a lot about blood pressure, but imagine someone with heart failure, just 10-pound increase gets them back in shortness of breath and back in the hospital, right? And we're talking about readmission penalties. We're talking about increasing cost of care for the population. But when you're monitoring, you're seeing that weight creep up. It's so much cheaper for us to tell the provider we're going to increase their water pill, higher dose, and get that weight down and prevent a hospitalization. So those patients are very grateful.
Well, we're holding their hands on a daily basis. If you just think about it, we're there. As you said, monitor when that weight goes up and that congestive heart failure patient goes up 3 or 4 pounds. It's not after they end up in their emergency room and in a critical position, and we prevent that. So communication is what we're talking about, constant communication with these patients. And I firmly believe that communication prevents a ton of problems that non-communication causes.
So then with that said, how much time does this take out of the pharmacist's day, out of staff members' days? What are you seeing? And if you can tell us what your ROI is on this, maybe you can or can't, but let's start with, how much time?
Well, Medicare has made it easy. You got to monitor for 20 minutes. That's 1 unit, right? So for every patient, and the 20 minutes are accumulated over a month. So I can monitor today for 3 minutes. I can monitor next week for 5 minutes. So it's a 20-minute accumulated time for the first. So if you say, and if you tell a pharmacy for 20 minutes, the revenue is about $50 to $55 for monitoring, and how you split with the providers, you can make the economics, right? And you don't always have to use a pharmacist for every step of the way. So our technicians are doing more in the monitoring as well, and only escalating. So I think Medicare has already given us a guidance. 20 minutes is the first unit.
And
So
that was $50, right?
Correct. But that $50, now you have to negotiate your fees with the provider.
Sure.
You have,
Okay.
you have to create that revenue split with the provider. And, one of my sales pitches, and I might have learned this from Amina, is you go to that physician, say, how would you like to have a pharmacist on your staff at no charge to you? A pharmacist.
And make you some money.
Yeah.
Give you value and bring us some net back. And it's at no headache to you, not your employee. I think I would always sign up for that.
Yeah. So you're providing a service for them. They're getting revenue, and they're not having to do anything. Almost nothing.
So I mean, and I know this has to vary because obviously you're negotiating a separate deal with every provider, but what do you think is reasonable, and what have you found to be reasonable with the providers you're doing business with?
I think the more value you bring, you probably could live with a lot of money. So if you just say you're just a monitoring company, well, that's what the technology is, but it's the pharmacy knowledge behind medication management, and getting those patients to outcomes and goals is the value. So with that, I feel like you don't go wrong, even whether it's 80-20, 60-40. And most of these services like Bob, I know Bob doesn't just offer remote monitoring. So this becomes an add-on to services that we're already offering to the practices.
Right. So what we generally do on the front end, because it's new to some of these providers, and we're kind of interfering with their clinic on the front end until we train that biller, until we make the staff understand what's going on. So, and I don't know what Amina is, but what I generally do is go in originally with a 60-40 split where the clinic gets a little more on the front end. And then after 3 months, we drop it down to 80-20 or 75-25, whatever we can negotiate to our favor.
Sure.
Because we are the ones that they're not doing the work. We are doing the work. And we really haven't had any pushback. 1 or 2 clinics pushed back a little bit, thought we were a little bit high, and they didn't use us at first. And then after 3 or 4 months, they had done nothing, and they came back to us and said, okay, 20% is better than nothing, So, and then after we get on board, they see our value and they realize it is a bargain.
And now it's hard to find any practice that is not being measured for their outcomes. So we had a practice that was doing remote monitoring in-house. They were having the revenue, but when they got their scores for one of their contracts, they had X number % of patients blood pressure not at goal. And I said, well, so what are they doing when they're monitoring? He said, Amina, I know what you want to tell me. I told you so. I said, no, I'm just curious. But I told him, just looking at the platform, that's not the solution. So they switched over to us because they needed to meet those goals. Patients were not at optimal doses. There were drug interactions. There was non-adherence. So he quickly said, I get the value the pharmacy brings.
Yeah.
Sure. And I have a couple of lines of questioning here, but that made me think right off the bat there. Is there a time limit? Will Medicare say, or, will they say, we aren't paying anymore? We haven't seen any improvement in the last 6 months or the last 12 months or whatever. When will they cut you off?
Thank you for asking that question. And this is why I believe pharmacists are a key to this. Okay. Technology that just monitors and does nothing is increasing cost of care. So if you're a practice with 500 patients making this kind of money and still your patients are ending in the hospitals, the ERs, and still costing, Medicare will find no value to this program. right? So that's why when I'm more pharmacy-driven service and use the technology of choice rather than a technology-led service that does not have the clinicians backing this up.
Well, I think it's like anything you want to, obviously your goal is to have positive outcomes. And if you're just monitoring and not doing something about it, then it is a waste of money. So we want to prove and certainly report those positive outcomes.
And is there a time limit, or is there, or or does it just vary as to when Medicare will say, okay, enough's enough?
The good news, Medicare is increasing revenue in these services, and it's adding additional code times that even if you go above 20 minutes, here's an additional $40 to $45 for every additional 20 minutes. So definitely Medicare sees this, and COVID may just have helped it.
I think that just proves the value when they do something like that.
Certainly. Okay. So, Amina, you mentioned that Bob does other things, and I'm sure you do too. I guess I have two questions that are related. First is, what are those other services? And then do you find that starting one before you start the other is important? So in other words, maybe remote patient monitoring is the first thing you do, and then you are doing this clinical service and this clinical service, or is there a clinical service that you should do before you're doing remote patient monitoring?
So all these remote patient monitoring, chronic care management, behavioral health integration, they all fall under non-face-to-face monitoring of patients between visits, right? You don't need to be at the doctor's office. You can do it from your pharmacy. You can do it from home. So remote monitoring is the newest one of these codes. We've always been doing, whether it's annual wellness visit, it's been a buildup on beyond office visits, what we can do with patients and what they call population health management. So if I think remote patient monitoring may be the easiest, Bob, correct me if I'm wrong, I think it might be the easiest. And there's something that hooks a patient.
Well, I guess the easiest is probably a good way to describe it. But as you were saying, there's so many other things that once we get the patient hooked, there's so many other things. And we're working on now that COVID is over and we can certainly go back to classroom settings. These patients that we have relationships with, a lot of them are diabetics. And so we do DSME, diabetic education for our patients. So rolling these patients in are a lot easier now that we have a relationship with not only the patient, but with the prescriber as well. Obviously pharmacy is migrating rapidly toward a more clinical services model. And I know we're close to the pharmacy school, and I have students through here all the time. I think we're going to push to having over 50 students come through my pharmacy this year. And these students are sharp. Their clinical knowledge is unbelievable. And putting them in a setting, a practice to where they can use that knowledge, whether it's RPM or CCM or annual wellness visits, whatever you want to do with them, it's wide open because we are building these relationships.
Okay. Yeah, that's true. That's great news. And you wouldn't say that there's one that you should do before the other, or would you say this is the easiest, so do it first?
I think it's about what the practice needs, right?
Okay.
And you have to be open and flexible. For example, I went to a practice and I was talking about these services, and they said, you know what? Our ACO wants us to have an annual wellness visit completion rate of 80%. Can you help me there first? So while it's not about us, it's about our collaborator and what they need and find valuable at this time. And then we can always add on to those other services.
I think that's a great point. You got to find out what their pain points are and see how we can work with them to help them resolve their pain points.
Okay. So, I was going to ask if is there an ideal pharmacy business model where RPM works best, but and I think you've kind of answered that. Can you expand on it at all?
Well, again, you've got to have obviously a clinical services model in place. That's the first place to start, which a lot of pharmacies do not. They're not thinking clinically. They're still in that reactive business model of just filling as many prescriptions as quickly as they can and getting the patients out the door, never really having a conversation. Well, that's an old broken model, and getting involved clinically with the patients is certainly your first step, whether it's just monitoring their blood pressure or offering a cup to check it in the store, or blood sugars, talking to them and getting more involved, which opens up, more and more conversations you can have. So.
Okay.
Yep, the business exists because we have entered value-based medicine, value-based contracting, and in order to provide value to the health system, one provider cannot do it alone. So I think pharmacists are poised with the accessibility, the knowledge, just the multiple patient interaction, and all this is evolving. I would hate for pharmacists not to make themselves a product that can be sought out for these ACOs, for these doctors who are getting penalized because they are not getting their patients at goal. Yet here we are, we have them in our database, we fill their prescriptions, we deliver to their home. There's no other healthcare provider that has this much access and insight to patients than pharmacy. So I would love for us to capture that. And that's why the whole mission about CPSN, aggregating ourselves together, becomes so crucial, that pharmacy have to lead the way into these services, or a new profession will be born called population healthcare coordinators. Take these codes, do them, and we've been there all along.
That's correct. And, I hear pharmacists just all over the nation saying, well, that won't work in my area. Folks, I'm in rural Mississippi. My town has a population of 8,000 people, and we're in 5 clinics in this area. I mean, it could be done anywhere. Pharmacists have got to realize that we are on the forefront, and we've got to act. And a lot of us have through CPSN, and glad Amina mentioned that. That's a great movement, and it's got legs.
So let's those that haven't done it yet. How do they get started? What would you tell them to do first?
First thing, they need to know that while it sounds simple, you do have to do work. So when people go through these trainings or they watch a webinar and they fail, they feel like this is it. I'm never going to do it again, right? It requires relationship building. It requires speaking a new language, because when you go to market to a provider, you got to know what their pressure points are. So those are important. So I wanted to make sure, because I know so many people, I tried and it failed. We failed many times before it worked. Mm-hmm. And it's important to know that. So while it could sound simple, you have to do a lot of work to make it work. There are many resources. I know I'll be helping CPSN write playbooks so we can get CPSN membership, to get this information out there, because survival of everyone is survival of us. There are many ways. We have Avant Institute. We have free webinars that people can look at. You can reach out to people who are doing it. Go visit Bob while he's doing MedSync. Look at what he's doing the rest. So resources are out there. Just don't bother Bob. You got to make sure you take him out to dinner first.
That's a prerequisite.
He's very busy.
Are there entities that will help with this? I mean, I think I read about a few companies out there that you kind of establish the relationship with the doctor, but then they'll reach out and talk them through the whole process of getting this thing set up.
Well, yeah, they've got to be trained. And Amina mentioned, Avant Institute, which is her model, and reaching out to CPSN and getting, just finding out where can I go? They can certainly point you in the right direction, or just visit your associations or NCPA and say, who's doing this? And where can I learn? You can't just sit back and say, well, nobody's teaching this or nobody's coming to me.
Sure.
You got to reach out to someone and be proactive. And it's out there,
And have the confidence, honestly, to pitch it yourself.
Yeah.
Okay. heart to heart, provider to provider, I know what you were saying. Some companies will be the gatekeeper and go in. A lot of our providers are tired of being sold things and everyone is trying to sell them things. But I don't think a pharmacist is really in that group because we have something that's very valuable they need. So the more you learn to speak the language, the more you are confident of what you can offer, those transactions go a lot easier.
Yeah,
Sure. I mean, that all drives to your credibility as well. And being that independent pharmacists are highly, one of the most highly rated professions, usually in the top 3 every single year, right? Using that, uh, it really does give you the credibility to talk to the provider. And I see what you're saying about using somebody outside. You're the one with the relationship. Have the confidence.
Have the
And learn.
confidence.
So,
And it's time to move from, I always say this, all those providers who like you, call you, text you, it's time to move from friend zone to business. They
right.
can help you unlock a lot of financial potential, but you need to show them how.
Got to be a win-win proposition, obviously.
sure. Well, listen, we're probably need to wrap up here. Do either of you have any parting comments?
I just did mine. No more friend
Okay.
zone. We've been helping them for a long time. They have tons of population healthcare codes that they can unlock and you can do them. So go for it.
And certainly if anybody wants information, they can reach out to me. It requires dinner, of course. But no, I'm happy to help, point them in the right direction. And, I want us all to succeed. It is, and Amina touched on that. This profession is about helping each other out. And I know years ago, certainly us independents, maybe we were at odds with each other, but, I have my neighbors down the road here that independent pharmacies that I want to see them succeed, and I will do everything. And Amina's the same way to help them succeed. And because I always learn something from them when I work with other pharmacies, I always pick up some information.
Absolutely. We're all in this together, and that's what
right.
we're trying to do here too at RMS. So, well, listen, Amina, Bob, I really appreciate you coming back and joining us again here at Climb, and it's been great. I think we had, there's so much great information in what we just discussed, so really do appreciate your time.
Thank you.
Thank you for having me.